I'm here today with Bridget Ingle, and Bridget is an international board certified lactation consultant and with a nursing background, and she's also got a lot of training in orofacial myofunctional therapy. And so Bridget and I are going to talk about what we have been discussing here today is how we can really optimise the 0 to 3 age group and their orofacial development. Hello Bridget, welcome.
Hi Mary, thank you for having me. It's a really important age group, 0 to 3.
So much we can do early on, isn't there? So you just want to go into a little bit of detail there about what your special interest in orofacial myofunctional therapy is and what that looks like.
As a lactation consultant, I am obviously mostly helping babies who are having difficulty with breastfeeding, which often means that there's some function that's not happening correctly.
Yes.
So I became more interested in helping with that, and I did a lot with suck training and utilising oral reflexes and positions of support to get the best use out of how the baby used this part of their body. So I kind of thought that that was very interesting and wanted to learn more about it, and I realised that for babies who are having difficulties, there were also children who are having difficulties in that area and adults who are having difficulties. Then I realised that those children, those adults, often started off with difficulties as babies. So I did this complete cycle. So I'm interested in this complex, which is the orofacial complex, or we call it the cranio-orofacial complex, which also involves breathing. So we actually call it the cranio-orofacial respiratory complex. And it's how this whole part of the body works with feeding, breathing, and eating,
and sleeping is the other
and
big
sleeping.
one. And I think you've just touched on there what we're all about, really, because we see it in adults, don't we?
Yes.
And we know that these problems start very early.
They do.
And that's why we're super passionate about trying to get in early to make as much change as we can to get these little people nose breathing, correct swallow pattern, sleeping well, eating well, all these amazing functions in the lower third of the face. That's why I wanted to come on and have a conversation with you to sort of talk about what we might find that we can do as parents to really make sure we're not interfering with this normal growth and development. So what sort of changes have you seen in 30 years of the support in the lactation work for a start? And then we can talk about what you think you can do to help.
I am incredibly fortunate having been in this profession as my only profession for this number of years. I have been around for long enough to see some amazing research in the areas of lactation, which is how breasts make milk and the milk itself, and the areas of breastfeeding, as in what is actually happening with breastfeeding. Ultrasound studies, MRI studies is telling us a whole lot that we didn't know before. So that's a huge privilege and quite exciting for me to have been learning during this period of time. So I've seen a lot more awareness of breastfeeding beyond breast milk itself, generally amongst the general public, but amongst health professionals, that they are very aware that breastfeeding is actually an important thing and it's quite a complex thing. So a lot more health professionals are learning about breastfeeding and wanting to help. On the other hand, I'm also seeing many challenges just in life that are interfering with the good progress of breastfeeding, and a whole lot of other circumstances of babies that we see create challenges for the babies themselves, because we've had a lot of changes just generally in our lives over the last 3 generations of diet changes, environmental changes, medical conditions, all of which influence the baby during the pregnancy and how they grow and develop, which also then plays out when they are a newborn and learning to feed. So I'm seeing things that I didn't see before in the babies themselves, with the type of shapes of their faces, the size of the inside of their mouth, how they're able to work. And then as time goes on, I'm seeing certain practices that are becoming more normalised that previously were not, that I see as being an interference to the progress that we would optimally hope for a baby.
Yeah, it's interesting to sort of what you talked about before, the nutritional benefits of breastfeeding, but there's also the mechanics of breastfeeding, which are really important for the function, and then the environment and all the different things that are going on that set up the optimal experience. And so just touch on the difference between, say, breast milk in a bottle compared to breast milk and the breastfeeding process. Just why you work so hard, why you're so passionate about trying to get that piece working for these mums.
Yes, or any kind of milk in a bottle, any kind of nutrition in a bottle is very different to breastfeeding. We have to remember that babies are born with the expectation to breastfeed. They're born with specific structures that should help them to breastfeed. They're born with particular mechanisms of that exquisite being able to suck, swallow and breathe while they've got a breast in their mouth, while they're transferring the milk and being able to swallow safely. So all of that is pre-programmed into them, which we call neurobehaviour. And they're exquisitely good at it. They should be exquisitely good at it when they're born. So they use different muscles. In fact, what we should be saying is that breastfeeding is normal. So they're using all the normal muscles, the right muscles to get the optimal use. So babies who are breastfeeding are using the large muscles of the face here, like the masseter, which is the one that goes from the cheekbone down to the jaw. It's a very big, powerful muscle. And they're using the mentalis to really drop the jaw really big. So that's happening on the outside. And we know that the use of those muscles helps to grow the face, helps to prepare the face and the space inside the mouth for later on. On the inside, the baby is using the tongue, which is a very powerful collection of muscles, but so clever in how it can move because the front, the middle, and the sides and the back of the tongue can all be doing something different at the same time. So the tongue comes forward and it gathers up the breast and it draws the breast into the mouth, and the breast completely fills the oral cavity. So the whole of the breast is being elevated by the tongue to the palate and spreading the palate. So the baby is holding on to this tongue using the right amount of pressures within the mouth while the back of the tongue goes up and down with the soft palate, while the jaw is moving, and all of that is happening while the baby is breathing through its nose.
What sort of things do you find are the big issues with the mums and the babies, the dyad as they call it, mum-baby relationships?
I would see things start off early as what's happened to the baby in the uterus, so potentially their position in the uterus, how much space there's been, whether there's been compression to the craniofacial region. So we may see babies who have had some positional constraints. Their jaw may be pushed back, their jaw may be deviated to the side, they may have a head turn preference, all of which may have been from the pregnancy circumstances, but also may have then become more evident during the birth process of whatever that birth process may happen. So I'm definitely seeing babies with those kinds of obvious things. I'm seeing very small jaws. I'm seeing very small palates or very high palates. So the alert for that is that you go back upstream and you know that the palate is formed by how the tongue is moving during the pregnancy and swallowing the amniotic fluid. So when you have a smaller palate and a smaller jaw, you've got a very much smaller space available in the mouth for the baby to be able to fill with the breast. So that's a big challenge for a baby. So we use a lot of techniques to be able to help the baby perform in the best possible way that they can.
You talk about the cranial distortion from the birth or the in utero, and or jaw being out of alignment and things. This is something I find in my practice too, and this is affecting a lot of that cranial nerve function, which really interferes with the way those reflexes are allowed to function.
Yes.
So that's the sort of thing that working collaboratively is really powerful. So a chiropractor and osteopath who's working with that cranial function, and then lactation support work is incredibly powerful combination to really help get that
totally agree
baby
with that.
function
Totally
really
agree
well.
with it. I have seen a profound increase in the use of dummies, and your word normalising, it's a bit scary that we're now saying that it's becoming normal, such as mothers aren't even hiding it. I think in my early days it was almost a task of mothers to try not to use a dummy. You would do whatever you possibly could to not use a dummy. Then I saw stages where mothers would ask me about a dummy, but they had it hidden in the bag, and they might ask about it, they might show it to me. And now I see it all the time, that it is probably more than 50% of the babies who come in are already coming in with a dummy in the mouth, no hiding. There's probably a whole lot of reasons for it. I think that marketing is very, very powerful. There's so many different attractive looking products on the market, and the wording that's used to describe each of the particular products can be quite persuasive to parents or mothers who are in distress about their baby's distress. So I suppose that's the thing that we're looking at, is what is normal, and normal is for a baby to want to suck a lot for comfort. Suck on their breast, suck on their fingers or on their hands,
That's
etc.
very normal, isn't it? That they want to put things in their mouth, and it's
part of their oral development to be using their mouth as a message bank as they go through their stages of oral development. But we know that it's also used for soothing, for neurological soothing and stimulation, as well as physical soothing for pain. Dummies are used in premature nurseries because babies are born way before they're having many oral feeds, and they're not capable of breastfeeding if they're born very premature, and not even bottle feeding. So they're having a nasogastric tube put in which bypasses any oral stimulation. So dummies are used fairly commonly, and they say successfully, often used when the nasogastric tube feed is happening. And there is some evidence that shows that that may help the baby progress to oral feeding and discharge from hospital sooner. There's also some research that may show that dummy use may be partly protective against SIDS for the young age group.
What age group would you say that's for?
Well, I think it's really in the early months, but the thing about that is the offset of introducing a dummy before breastfeeding is established, that then there can be this preference or confusion that can happen. So that's often a balance. But what we do see is that dummies can be used as a form of airway splinting, because the dummy is in there and the tongue is being held out of the airway. That may be the reason why dummies help with SIDS.
It's interesting, isn't it?
And it may be the reason why some babies continue to use dummies for a longer time, even through into toddlerhood. The difficulty comes is when you think about what's actually happening with a dummy in the mouth. Under normal circumstances, when the baby is not having a breastfeed, the baby or eating food, the baby or the toddler up until the age 3 would have their mouth closed, their tongue would fill the palate, and they would be breathing through their nose. Then when their mouth is open, they're putting food in, they're moving food around, or they're exploring their mouth. And they're the normal behaviours. When a dummy is placed in, and it's placed in for a period of time, it's occupying a space that the tongue would normally occupy, or that the moving food would occupy. So the tongue is being held down, the palate is being pushed up, and the lips and the cheeks are being used rather than the big jaw muscles here. So we know that it's going to change the shape of the palate, it's going to interfere with the growth of the jaw, and it's going to create abnormal muscle actions of the tongue and the cheeks and the lips. So the research shows that dummy usage after the age of 12 months starts to create this prevalence or this persistent of the tongue thrust action, this kind of action,
rather than a learned pattern.
A learned pattern rather than a closed mouth, lifted tongue, swallow pattern. And then continued use after the age of 2 will cause permanent craniofacial bone changes. Where there's bone changes, the muscles compensate, and then the wrong muscles are starting to be used to create the same task, rather than the right muscles are being used. I think it's really important to make parents very aware of this, because in their early short-term distress, they may not realise that they're actually making a decision about something that's having a long-term influence on that child's orofacial development, cranio-orofacial development. I think it's important to try to identify the cause for why the parent might feel that a dummy is necessary. Sometimes it's for the parent's well-being, sometimes it's for the baby's well-being. So I try to get to the bottom of that, because it may be something that we can help with that can either eliminate the dummy introduction or use in the first place, or at least really, really minimise it, rather than use it as a band-aid effect. With communication, because we're talking about the 0 to age 3, this is when language is developing too. And so the child will be inhibited from expressing vocalization, sounds, communication, words, if a dummy is in the mouth and they're just going, The dummy rules. All right. First of all, I would be saying to choose the smallest, most boringest dummy that you could find. So we don't want one that's going to fill too much space in the mouth, to be pushing that palate up too much or holding that tongue too down. So the smallest one. Definitely not one that's got any angles on it, because the tongue is going to wrap around whatever shape the dummy is. So some of them have got an angle, which is going to be holding the tongue at a very abnormal kind of, an extra abnormal kind of position. So we'd be looking at something that is nice and oval or rounded rather than having any angles on it. Also to be thinking about what's happening here on the outside, whether the size on the outside of the outside support, if it's curved in towards the face, if it's hard, if it's flat, if it's curved away from the face, how heavy is it?
I have seen some things hanging off dummies, that's right.
Hanging off dummies, that's exactly right. Then I would be saying to allow the baby to have it for the shortest possible period of time until they're settled, and then to slip it out, which may mean they're still awake, it may mean that they're asleep. If they're asleep, slide the dummy out and then close the baby's mouth, not just their lips, but what we're trying to do is get the tongue to the palate. And the parent can help the baby do that, or the toddler do it, just by pressing there, which is where the base of the tongue is, and just holding it like that after they've slipped the dummy out, and then a little bit of a push like that, which seals the lips together. So we have then completed the circuit without the dummy being in there. We've been able to put the tongue to the palate and close the lips so that all of the happy signals are going to the baby's brain and tells them that everything's all right.
Thank you, Bridget. It's been great to spend some
Mary.
time talking all things oral facial development in the first 3 years of life.